So as we talk about the precision, we are going towards a target 2020. The whole idea is to be very precise in our surgery and targeting the astigmatism and neutralizing the pre-existing astigmatism to anything less than 0.75 theoretically, but practically what I always target is less than about a zero point 0.5 or a bang on emetropia, because all said and done, slight errors may remain due to various reasons. Now, the most important key for the successful surgery and treating the astigmatism is recognizing the correct astigmatism and right clinical measurement of the same. Then review the design and choose the right IOL which fits in best for your patient, and you can always understand and reshape the cornea once you are still left with any residual astigmatism. So while measuring, as was being discussed by Dr. Chilana, the most important thing is understand your instruments. There can be multiple instruments at your disposal, so you can go ahead and check your patient on multiple instruments. And if you don't have the same, if you have a limited access, take multiple readings on different occasions so that you get an average out of most of the readings and you know your accuracy levels. For the right accuracy levels, your K reading should not have a difference of more than about a 0.5 between various instruments and at different occasions. And the X's should not be anything more than a 10-degree difference between the two readings. So once you get all this, I generally take multiple readings on multiple instruments and take an average out of it. This is what fits in my clinic and my patients the best. But always understand to calculate your posterior corneal astigmatism. Now are the days that you cannot neglect this entity, and if you are not very clear about it, you may land on with overcorrecting with the rule astigmatism, and you may undercorrect and against the rule astigmatism, because most of the corneas, remember, in the posterior surface have a little plus value at 180 degrees. So the newer generation instruments like the tomographers have all this entity built in this, and they calculate the total corneal astigmatism. Here is an example of IOL Master 700, which gives the anterior astigmatism as about a 0.5, calculates the posterior astigmatism and neutralizes it to 0.39. So which is something which may not require any treatment and will be corrected with just the surgically induced astigmatism of the surgeon. So another example of another instrument, Antrion, which gives multiple excess of calculating the total corneal power. It gives the entry level for the incision, that where to enter it. How much is your surgically induced astigmatism, you can select and put. You can put the right A constant by selecting the IOL, and of course has an overlay options where you can just see that when to rotate and what will be the final astigmatism correction you get into it. And all these come with a posterior, anterior measurement, and thus they give you the total K value. So after you have done the right calculations, it is to select the right IOL calculator, feed in the data in the calculators, and see that what astigmatism correction does your calculator say and where to place the lens. After having placed the after having calculated all the things, you need to understand the right IOL design and which IOL has got the proper rotational stability. Like if I am doing any eye which is a post-refractive one, which will not have the right a constant value, so there would be the best to choose an IOL which would have a zero asphericity, like the Bausch & Lomb Investa and the Auroview toric lenses, which have got a zero asphericity, and most of the lenses like the Technis Pure C come with a minus 2.9, which neutralizes the normal asphericity of the cornea. But mind it, whenever we are dealing with the post-refractive surgery corneas, their asphericity is already changed as compared to the normal ones. So need to understand that which IOL for which eye would be fitting the best. So once we have decided, then is the choice for the rotational stability. In my previous days, we used to see that the Technis lenses never used to give us a very good result, and the rotations in these lenses were very common. And those were those depressing days where I generally used to feel that I am not a good surgeon, and all my toric calculations, once I am doing in the best possible way, still the patients used to land up with a little residual error, which was not to the expected level. But after the introduction of the newer generation Toric 2 platform with the Technis and the with the Technis and the Pure C and the iHands ones, which have a frosted haptic design, the stability is so good that the rotation is less than about even a 1 degree. And the results are so bang on that the results in most of the eyes, I generally expect that the astigmatism residual may not be more than about a 0.5. So the IOL design is something very important, and it is not only the surgeon's placement which would decide the lens stability. Here is just a small video to show how to plan a toric lens. So first is placing the patient and taking the right markings on the eye. You can do it by various ways, like once you take the patient on the slit lamp, you make a horizontal beam, and you can manually mark the 0 and 180, or you can take a bubble marker and just make the patient sit straight and just place the bubble marker at the right alignment to get the 0, 180. And second is just identifying the right 90 degree and where you can just make the mark easily. So different techniques are available, but you need to decide what is most comfortable for you, and you need to select the same. After having put the right markings, you take the patient in the OR, place the ring, and take the desired plane where you need to place the IOL. After having completed the surgery of course has to be very reproducible, and you need to optimize your SIA for a good toric outcome, because all the calculations are based on the surgically induced astigmatism, how much your incision is going to give. Placing the lens and a good visco cleaning is the key to success for a good toric outcome. But still, you may have a case like this where the patient came to us 2 weeks later and had a residual astigmatism of -5. This patient's corneal astigmatism was mere 2.25, and I was surprised to see such a huge astigmatism. Probably whosoever had calculated had messed up the K readings with the 90-180 misalignment, and the lens was placed at almost a 90 degree different axis and was placed at 90, which was actually supposed to be at 180. So the astigmatism doubled in this patient, and what the pre-op was 2.25 landed up with a 5. So as it was about a 2 weeks old surgery, we had to carefully nudge the rhexis margin and dissect the IOL from the anterior surface and clearly separating in a very careful way so that the PC is not ruptured. And after having done a slight disruption of the anterior capsular margin, we injected the visco, which went into a very smooth plane and dissected the lens from the anterior capsular margin, and the IOL could be easily rotated and placed in the right plane. The patient had an excellent result post-operative, and his astigmatism was neutralized. So in spite of all things done, we can also reshape the cornea once we have a little residual astigmatism. And generally for a slight lesser value, say about a 0.5 to about even a 1.5, I generally do not tend to reshift the lens or take the patient in an OR, where I can directly do it just by neutralizing the steep axis with my incision only. If the astigmatism is only up to about a 0.5 and I still want a better precision up to about a 0.22, I take an SIA of about a 0.5 to 0.18, which is my normal incision, And when it is more, I even tend to take a little larger incision and I extend the incision up to about a 0.5 in these cases. LRI can be done manually, but the best way to do it through is the femto laser if you have an access to it. And double CCI may neutralize an incision up to about a 0.75. So this was a young male where the patient had an astigmatism of about a 0.75. I had to implant an VVT and I took the help of an LRI with a flax where the incision got neutralized and the patient did fine. And an astigmatism of about a 0.9 where I actually planned to choose a double CCI which worked the best to neutralize it up to about a 0.8 or 0.75, and a residue of about less than 0.5 was well accepted. And yes, if you are still left with some biometric surprises or a larger residual powers, then of course bioptics is at your rescue, where you can treat the cornea by your excimer laser. Thank you.
Any questions from the audience? Dr. Piyush, like you said, after LASIK surgery, after myopic LASIK, what type of aspheric lens are you going to implant? You mentioned about zero asphericity in Vista and Oro, but where are the patients you will implant zero asphericity, positive asphericity, or negative asphericity?
See, mostly, sir, for the RK eyes, I generally prefer a zero asphericity. But for the this LASIK treated eyes, I generally tend to see that what is the quantum of correction the patient has received. If the patient has received a very large myopic correction, then generally these corneas are comparatively flatter and their Q value is changed. So again, in these patients, the patient may be happy with a zero asphericity lens, but if the patient has undergone a very minor correction, say up to about a 3 or 4 diopter, even the normal regular with a minus asphericity lenses would be doing fine in this, like the Tacnis and the Alcon.
Yeah, and one thing is, if patient has undergone hyperopic LASIK, the conventional spherical lenses will do much better than aspheric lenses in these patients.
Yes, yes. The conventional, because in them the cornea is in the opposite side.
In the opposite direction.